we're here with a program that's going to be called Understanding the Science of AIDS. And it is complex. It's the most complicated disease ever happened on the face of this earth, I guess. And we prove that year after year after year. We just had that program that we just talked about, the partner program to this on antivirals and the science, the bench science, and so forth. Now we're going to talk more about comorbidities and co-diseases, which are sometimes very confounding. We used to have, in fact, the name of the conference on retroviruses and opportunistic infections, was about opportunistic infections, which we see so little of today because we know to treat people, as you said on the last program, early.
Right.
Now we're really still seeing comorbidities, which means other diseases that are affected in a somewhat dramatic way, and maybe we can start there with and by the way, this is Jim McDonald from Kaiser Permanente here in Portland, and we appreciate you taking the time to spend with us here.
So the laundry list is very long, Fred, as you know.
Let's just touch on the important ones.
So I mean, there's the whole metabolic syndrome, and so this involves things like hyperlipidemia, so elevations in cholesterol, particularly triglycerides, alterations in what we call the HDLs, or the high density lipids. What I talk to patients about, these are the good guys, so these are the protective cholesterol. For whatever reason, which we do not clearly yet understand, people living with HIV, on or off antiretroviral therapy, cannot manufacture high density lipids. So technically then that puts them all at risk of cardiovascular disease. Matter of fact, living with HIV carries the same weight in terms of cardiovascular disease risk as does living with diabetes. And if you're so blessed as to be living with both HIV and diabetes, then you've got the double whammy. Yeah. So, and then the LDLs tend to run a little high as well. So that whole lipid metabolism issue, and then lipid meaning fat, and also then people get non-alcoholic steatohepatitis, which is basically fatty infiltration of the liver. And normally, I think back in the day, we never really thought much about fat infiltration of the liver. It was low on the priority list, but nowadays, people living longer, and if they're drinking alcohol, taking a lot of acetaminophen or other hepatotoxins, not taking good care of themselves, fatty liver infiltration can be just as serious as any other chronic sort of hepatitis and lead to cirrhosis, chronic liver disease, and bad things. And part of that metabolic syndrome, of course, is the diabetes. People develop insulin-resistant diabetes. Again, we don't know exactly why. Is it the antiretrovirals? Is it the chronic immune activation? Is it chronic inflammation? What exactly is interfering with, insulin unlocking the door to the cell to allow the glucose in so people can metabolize sugars? We don't exactly know, but it happens. So, of course, we watch these things on our patients religiously. Everybody gets screened for diabetes every year. Everybody gets screened for lipid abnormalities every year. People have elevated LFTs. They get an ultrasound of their liver. If it shows fatty infiltration, then they're counseled, low-fat diet, high fiber, more exercise, no alcohol, no Tylenol. I always tell them no wild mushrooms as well, because you never know what you're getting.
So you're really singing the song that I like to sing.
Yeah, nutrition and exercise. Yeah, and it's true. We've talked about this too, Fred, in terms of the HDLs, the good guys, in terms of the good cholesterol. We really don't know of any impact on those other than exercise. So men who exercise more, and when we say more, we're talking like an hour a day, 5 days out of 7, they will push their HDLs up. And women as well. I have a terrible problem with this because most of my patients are men. Right. So all those metabolic things, and then of course we don't know what the newer regimens, that we're starting young naive patients on. We don't know if they will still end up with these same metabolic disturbances or not. One of the big issues, of course, for people with a long duration of illness who've lived with HIV since the 80s or 90s is the whole lipodystrophy, or the fat redistribution problem with truncal obesity and thinning of the arms and legs and facial atrophy and all that kind of thing. So again, something we don't clearly understand the mechanism for, and we certainly don't have a magic bullet. We have no pill that says, if you do this, this will happen. Even at this point, redesigning antiretroviral therapy does not seem to impact it that much. So certainly we see lots of other comorbidities. Chronic kidney disease is a problem for people living with HIV. HIV in and of itself causes what we call a nephropathy, HIVAN, HIV-associated nephropathy. Tenofovir, which is Viriad, which is part of Truvada. It's in Atripla, it's in Complera, it's in Stribild. Is a known nephrotoxin, or it can injure the kidneys, actually injures the renal tubules. So again, we watch this in our patients very carefully. We watch their creatinine and their filtration, their clearance rate, their filtration rate, their urine religiously to be sure that they're not suffering any kidney injury. Bone metabolism is a huge issue. Vitamin D deficiency, particularly in our patients who are getting older, over 50, over 60, really hound them quite a bit about diets adequate in calcium and vitamin D, there was nutritional supplements of calcium and vitamin D.
I guess it was, for the last 2 CROIs they had programs on vitamin D.
Yes.
So there's been more of, it seems that this is profound. There are a lot of simple issues, but this one seems to be.
Well, and I think it's always interesting, Fred, this is something I have found over the years. Years ago, I don't remember what year it was, I'd say maybe 5 years ago, at CROI there was some conversation around vitamin D deficiency, osteoporosis, osteopenia, low trauma fractures, etc. And it was really kind of dismissed and shoved out into the cold. And I think we were in Boston. I can't remember. It was freezing ass cold. I know that wherever we were.
It was 12 years ago when William Powderly, who was then at the University in St. Louis, now he's in Ireland, I believe, dropped the bombshell at the very end of a presentation. He said, and then there's osteopenia and osteoporosis.
Yeah.
And it was almost like everybody got chills up and down their spine. We're thinking, oh my God, what now?
Yeah.
And that was the first he had broached it, because they were just starting to see that.
Yeah.
Because it takes time for that.
Right. Yeah. And so a lot of the data that was presented, I remember this particular conference from VA and stuff. It made it sound like, this is not real. This isn't really happening to our patients. But then each year, more and more. And then, like you say, last year, there were 3 or 4 presentations that talked very specifically about this and screening, what's the right thing to do and what age to start. Cardiovascular disease was the same way. You probably remember years ago when they totally poo-pooed. They said there's no difference. People living with HIV don't have any higher incidence of coronary artery disease or revascularization or heart attack or stroke or anything. That's a bunch of BS. And then, of course, we as clinicians, being on the front line, we knew, when a 35-year-old, 45-year-old, either drops dead of a heart attack or has to have a 4-vessel bypass graft, that's not right, especially if they're a non-smoker and they're slim and, So I think you do have to be careful sometimes with CROI, because they're presenting very pure data that they have analyzed from, populations that they have selected and monitored. So it doesn't always translate well into the clinical field.
Well, the other thing too that this is one of my pet peeves, is we talk about, and many times the pharmaceutical companies do the research as patient years. And it's not for the reasons you just said on cardiovascular, osteopenia, and osteoporosis. You need to understand real people on real time.
Yeah.
And then you start to see things. We still don't know if we've seen everything, but
it's like my primary area of interest, as you well know, is the prevention of anal cancer and anal dysplasia, which is a quote unquote non-AIDS related malignancy. And it's actually the second highest one. Adenocarcinoma of lung is actually number 1, and then anal cancer, and then hepatocellular carcinoma. And of course, hepatocellular carcinoma is tied in with the whole chronic hep B, chronic hep C situation, and the fairly rapid progression of liver fibrosis and sclerosis and cirrhosis and ultimately cancer. But, anal dysplasia is still not, I was just reading a study the other day. They were talking about the latest data now for MSMs, men of sexes men living with HIV, their rate of anal cancer is 120 per 100,000 person years or whatever, which is huge. I mean, the general population is like 3 per 100,000. So when you can look at those metrics in comparison to here's the whole world over here, just general population in the developed world, here's MSMs living with HIV, 320. That, that's brickbat therapy.
Yeah.
Okay, we got a problem here.
Oh, God.
And I mean, again, I can tell from my own clinical experience, just in the terms of the numbers of patients in my little tiny practice of 1,100 patients that I've diagnosed with, invasive or superficially invasive cancer, precancerous lesions. It's a phenomenally high.
I know Jeff Taylor is going to be interviewing Ron Manciasu from the AIDS Malignancy Consortium.
Yes.
And there's a lot of, we got really good interviews going, and some really people that are really invested in the science of the CROI. So I kind of get, at this point of the year, I get kind of excited about what's going to be there.
Me too.
And of course, the opportunity to interview some of the leading scientists, those who you're going to see in the poster sessions, many of them. And one thing I did notice, a lot of the docs that are on the lead, sort of supposedly the lead or the principal investigator, they're switching roles. They're trying to put the younger folks at the lead. And I think that's always good.
Yeah, that is good.
Because the thing is, there's so many of us are getting older, and sooner or later, their retirement comes along. And then you say, where is so-and-so? All of a sudden there's people are, gone. And there are people like John Bartlett, who's really amazingly committed and staying on with his, keeping on the drudgery of going to all these conferences and doing the work. But some of them are retiring. So I know some of them are stepping back and allowing the younger people to come in. And that's one of by far his big things, is trying to promote, more young investigators, brighter people into the field.
Yeah.
So I don't know.
Yeah, I know that passing the baton is so critical.
And I've had a lot of docs that have felt really good about it. Of course, the young investigator meeting that they do prior to the CROI is really exciting. They do a great job bringing in some of the best and brightest there to talk on the subjects, and there's a lot of good conversation. So that's another part of the conference that you have to be there for, kind of. But it is exciting. But I really appreciate you taking the time with us here today, and it's always exciting to get prepared for the CROI, and you're going to be going, so you'll have the...
And Dr. DeNowden from the county is going to. We're the only two that I know of for sure.
Right. Well, there's always 3 or 4 from our county, and population areas this big should probably have that many.
At least, yeah.
Well, thank you very much again. I appreciate it.
You're welcome, Fred.